Who has given a long introduction. In fact, most of the things what he has introduced, all those things has been possible since last 3 years because of one because of a biomedical engineering student who is working at our SS hospital. His name is Satish. I think today if I am standing in front of our engineering faculty, it's due to one of your students who works day in and day out with all our biomedical equipments. And though he is not here, I would like to thank him. And because of him, I got connected to Sir and to Mr. Nandish and to some of the students at BIT who successfully did a project with us. In fact, it was their concept. And at this outset, I would definitely want to say something. That is, most of the medical equipments, whatever are there today, though they have been invented by Westerners, the recent developments, whatever has occurred, it is due to Indians, those who are not in India. So in fact, the brain behind all these gadgets, whatever is there, if you see me at my ultrasound clinic or at the X-ray center or at the CT or MRI, so most of the top-notch brains who are behind it is one person, somebody who is like you, an Indian. Basically, why is it very much essential today? Because we are saying advances in biomedical instrumentation for quality healthcare. So why are we not able to deliver quality healthcare just like what it happens in US? What is the reason behind it? The reason behind it is cost. And why is it costly? It is just costly because we are not the ones who are inventing things. We are not the ones who are telling the world that this is how it works. If you just take the population, see, I am going little out of the track because my talk needs to be relevant to everything. See, if you see all the medical literature or medical equipments and you see the population, so most of the population of the world lives in either in China or in India. Okay, so if most of the population is there in India, then why does medical literature is depending upon the Western studies? Have you ever thought if somebody says crocin works for fever? Okay, if there are only 1 lakh people in UK and if there are crores of people in India, how are they able to say that out of only 1 lakh we have studied on 10,000 patients and we say that this is a drug? That's not right. We have the population, we have the brains, but only thing is we don't work together. We don't work together. Really, in fact, if you see any of the literature which is published by foreign countries with regarding to biomedical engineering, right now I am working with Professor Asha Lata also on some of the project. So, if you see, most of it is with the doctor, with the engineers, and some of them, even some social people are also involved with those things. Why is it important? If you just take a scenario like tuberculosis. Tuberculosis is so common in India, and it is treatable. Still, it has been cause of death and it is cause of suffering for so many of us. What is the reason? A simple rural person has a cough for more than 3 weeks. The basic thing what is required is a chest X-ray. Is it there in the hospitals? In the periphery? It's not there. Why is it not there? Because when they send a quotation for an X-ray machine, the Siemens and GE and so I hope no company people are there. They are the people who will come up with the machines and the quotations. And why are we buying their machines? Though there are Indian companies manufacturing X-ray machines and if you want a digital X-ray, it is again Fuji, Kodak, all these Japanese and those people. Why it should be like that? So that is where it is very crucial for all the teachers who are teaching students, both the medical teachers as well as the engineering teachers, to make sure that you just have to put one, I would say, if you have to tell in very colloquial language, one hula or telel bit pudbekaste, that they have to do this. In fact, the earlier project what we did on an Android application on remote access of images, in fact it got published also, which we worked with Professor Huli's students. In fact, when the concept came, even the US people were not doing that on a clinical thing. But we were delayed. There was a delay because we don't work together. Maybe when the students want to meet me, I am not free, and when they are having some sort of exams, we are not working together. In fact, when they came up with the whole thing, by then already all the teleradiology software companies, they started coming up with, okay, Android, we can see the radiology images on the go wherever you are. And now we want to, though our students put a lot of brains and time into it, they will never be able to put it up in a real-time practice. So that is the major key for everything being costly for all of us. Believe me, I don't know how many of you have undergone an MRI scan or anything. If somebody has undergone an MRI scan, please lift your hand. So how much will it cost you?
10,000.
How much?
10,000.
10,000. Okay. So why is it 10,000? Did you ever think? No, it's okay. 10,000, but you saw a very big machine and a lot of AC and lot of high-end infrastructure. So all those things are designed, manufactured elsewhere and comes here. So most of it is a tax. So your 10,000 has got a lot of tax in it. Means the person who has purchased that machine has paid a lot of tax to the importing. So once they have imported, he has paid everything in dollars to the other companies. So your rupee is going, though maybe if you think if a person is earning 100 rupees and if he has to shell out 50 rupees for a investigation, it's not good. And why is it happening? And believe me, recently I visited the GE Research Center at Bangalore. So they are trying to come up with new things like if they can reduce the whole cost of the equipment. Supposing if the whole cost of MRI scanner is less than a crore, then your scan charge can go down as least as hardly about 1,000 rupees. So there is a 10 times escalation with regarding to the price. See, that is where I think we all need to work together. A simple software which can manage clinics or radiology clinics or anything. Say a patient comes, he visits a doctor and then he goes back. So supposing I run an eye hospital, I'll tell you. So you go to an eye clinic, so you go to Vasan Eye Care and you go to any other clinic. Vasan Eye Care has got a software, they will register your name, they will give you a visiting card, they give you an identity card, and they have all your data throughout whenever you go there. But that scenario will not happen to a local ophthalmologist who is working in a periphery or in a government hospital. In fact, all those data is very much essential to do a research. That is why the Westerners are coming up with a lot of papers and they say, okay, this drug works for cancer, you have to believe. We will have to believe blindly. In fact, most of the treatments what we are following are all Western treatments, and in Indian scenario it may not work. Like Leander Paes, he had something called a cystic circus in his brain. The whole of the US, nobody was able to diagnose that as cystic circus, which can be treated only with medicine. They said he has got a brain tumor, he has to undergo surgery. So that is their level. In fact, they are very ahead of us in time. What I would say is, if faculties like engineering faculties and the medical faculties, definitely, some of us may be beyond 40, some of us may be at 30, some of us may be at 50. So whatever potential is there, so we need to make sure that people who get trained under us, they know the value of doing research, value of doing innovations. And those innovations are the ones which can happen through the engineering stuff. With this brief introduction, I will just run through a same talk what I had delivered in BIT. So we will go through very basic things. See, he is a German physicist called Wilhelm Conrad Röntgen. He is the one who discovered X-rays. He is not a doctor. Okay. So most of the innovations and new things are happening not by doctors. It's by physicists, it's by engineers, it's by other people. So who are the others in this scenario? In this scenario, it is we have grossly labeled it as an engineering section or a research section. There are two things. One is instrumentation and the product development. All those things come under your territory. And once you have developed something, using is by the doctors, we'll have to give you a feedback. See, you have done this particular product. See, nowadays what is the research, what is going on? So many diabetics across India. So now people, if you have to check how many are diabetics here. Okay, how do you check your blood sugar?
by doctors and as well as by using strips.
Yeah, by using a strip. How much it will cost you?
For 25 strips, around 600.
Yeah, around 600. Now, and it's not just the strip, you have to prick it every time, right? So, believe me, you can't keep a count how many times you have pricked yourself. So, there are innovations which are going in non-invasive detection of blood sugar level. Just like how a pulse oximeter is there. Earlier we used to, on the anesthesia, doctor used to stand at the head end and used to keep a count on the clock that what is happening to the pulse. Now you got simple pulse oximeters which will cost as low as 3,000. When it came into the market, it was about 10-15,000. It was 10-15,000 because others discovered it. Now it is 3,000 because Chinese are manufacturing it. Then what are we doing? No, it has got a relevant and significance. You can deliver quality healthcare only once it is affordable to our society. Because I'm sorry to say we are all very poor country with regarding to rupee versus dollar. So this is all very simple thing. If you just take your own, like sir is a diabetic, if it totals the amount what he's spending on the strips, and then if somebody can come up with a solution where he can reduce that cost as well as the prick. Cost is one thing people can afford, but if you can reduce the number of pricks, I hope you will be very happy if you can detect a blood sugar level maybe just by something like a pulse oximeter. Maybe something like you are just able to see the retina and say, okay, this much is the sugar levels. So if those things can happen, so that is what is innovation. So we see a lot of these small problems around us. So we will have to choose one of those problems and work on it. So that is where it becomes interesting. Otherwise, most of the times we see Western literature and we need some sort of a promotion. So we'll have to do some sort of a research and get our PhDs. So what we end up doing? So I have to publish 2 papers within next 2 years, without which the institute is not going to promote me. So I'll do something and publish and then fine. So that type of attitude is even due to the hospitals as well as the management who say that you do this only then you get it. They are not really looking into the problems. So just simple mobile applications if somebody can develop to keep a track of all the sugar level of the patient. Supposing everybody uses an Android phone. So if you have an application which can say, give you full chart of your blood sugar levels for the last 1 year. Won't it be very fantastic? You don't have to recollect anything. And if that particular chart can go on a SMS or an email or on a WhatsApp to your doctor, so definitely when you're going for your next consultation, he is also well aware and planned to say what exactly he has to tell. So these type of small innovations is what we are looking at. We are not looking at something like manufacturing a MRI machine. They have already done it. And there are already people who are working on reducing the cost. So we need to try and pick up problems. So he was not intending to discover X-rays. He was doing some other research and then he discovered X-rays. And then what happened with that? He was able to take this picture of his wife. So it is Mrs. Ranjan's hand. And that's the ring. This is the first X-ray ever which has been taken and it's not by a doctor, it's by a physicist. And now what is happening is this type of X-rays we are able to clearly see. We can see this. This is a digital X-ray. So there is a total paradigm shift. So how all these things happen is it keeps evolving time to time. So when I was a postgraduate, we used to go to a dark room. If most of you would have taken those passport photographs, and then if it's a black and white, he will develop same day and give. If it's color, he will send it to Hamsa lab in Bangalore, and then it comes after 3 days. Then what happened? Now what has happened? Now you don't, first thing is you don't need a passport photograph because most of the applications are online. So you can take a screenshot of your face and then you can upload. So the same way the radiology has also improved from these black and white images to 3D, 4D type of technologies in all the things. So we are, when it comes to my own specialty, let's not talk about blood and all this sugar. So if it's radiology, then it was all black and white. Now it has become completely different. We are able to do molecular level imaging. So molecular level imaging is we are able to say biochemically that this particular cells have got this particular biochemical content without doing any in vitro test. Only with the MRI on the cells there is something called a spectroscopy, MR spectroscopy. we can tell whether this particular brain lesion is a tumor or is it an infection. So if you are able to differentiate those things, so that is where it has evolved from these black and white pictures. So if you see from radiography then it is ultrasound which came, then Doppler, 3D and 4D scans. So when these things were parallelly happening, once radiography came, then the CT scan also parallelly came. Because CT scan and MRI scan, in fact the magnetic resonance technology wise, it was discovered much earlier than the CT scan. But what happened was the CT had a rapid progress because people already had an experience of X-rays. With the X-rays, what all things are happening. So X-ray passes through a body, and if it's an energy which passes through a structure, and structure can absorb some amount of energy and the energy comes out. So whatever less energy has come out, that can be used to create images. So earlier we used to have those photo studio type of X-rays where dark room and then dip and dry it and give it. And now we have all this hi-fi CR and DR X-rays. Recently we saw a demo of one of the computerized radiography. It's a Wi-Fi based model. The X-ray machine is same. The moment you click, they have a panel instead of the whatever you might have seen the cassettes in which they load and they keep. I think most of you would have got some sort of an X-ray done. I think at least, how many of you have got the X-ray done so far? Okay. So at least I think 6-7 people have got an X-ray done. So some of them might have got it done on those dark room where they give a wet film and ask them, hinge idkoli, onagli, aamel tagondhogi torsi. So now we have those X-rays which are computerized radiography. In fact, what we have is the cassette has to go into a reader, and from the reader the digital images are taken into a computer, image comes. Now what is there? From those PSP plates, we have those detectors. The cassettes are nothing but detectors, and these detectors are Wi-Fi enabled. So the moment somebody clicks a X-ray, it comes on a laptop. Everything is on Wi-Fi. So there is no wire. So this is how people integrate different things. So you will have to think little out of the box. So why can't an X-ray be taken by a mobile phone? Is it possible or is it not possible? Though it sounds very absurd, because so much of kV and mAs of power is required to create an X-ray. There is a cathode and anode, and then only when the cathode, anode and all these atoms will hit, only then the X-ray is generated. And why this doctor is telling, can X-rays come out of a mobile phone? So these are the things which is a pure research, and to do these things we need a lot of investment and those things. We need a lot of funds, we need that type of laboratories which are not available. So we will have to balance. What we have is, we have a lot of patients, we have a lot of technology which is coming from abroad. So can we do something better with mixing all these things? So then from the ultrasound CT, MRI came, and then MRI scans are there. Now we have PET CT or PET MR, then we have interventional radiology. So it is like, it's something like this. The MRI scan is there, and then it's a new age dinosaur. If you enter into any of the diagnostic center, it's like more like a dinosaur. Most of the times you won't know what is happening. So the doctor would have said, you have to get this done, get these things done. You enter one diagnostic center and you see a lot of those circles, the gantries, and they say, okay, you have to get it done. So you get it done. So it's become so much confusing to the general public as well. So in fact, even if there is something like, if there can be a mobile application which just dissipates common knowledge about radiology tests to public without any pay-per-use model, if there is an application which can guide and educate them, even that itself is a good innovation. If today somebody has to go and meet some particular doctor, they have to think so much. So one of the companies which is being developed by my colleagues in Bangalore, some doctors at KMC Hubli, they are doing, it is called some doctory. So if you log into their website, so they have created a website so beautifully that public can choose the specialities, they can know the credentials of the doctors, plus they can know, okay, if this particular disease is there, whom to go and meet, they can even book their appointments. Even creating such a website itself is an innovation. Because now every person is, and those creating websites and all this is, I don't think it's a doctor's job. Definitely it is to be from the engineering side. And only when people get dedicated to do few things, it becomes better and better. So there is, in fact, this is a American College of Radiology article called Radiology in 2022. It's published in 2013. It's in Journal of American College of Radiology. And you see this, what is this name? It is called Krishnaraj A, right? So that means he's an Indian who is in America and who is writing these things. Challenges and opportunities in the coming decade, proceedings of 12th Annual ACR Forum. So 2022 is almost, I think, 8 years from now. So this is 10 years before 2022. They have planned everything. What are the challenges? What is going to come up? And if you see these challenges, so nothing is on a pure research. Out of 5 points, what they have thought in 2012, only one is pure research and innovations. All other things are the auxiliary things, like patient-centered radiology, information management, future payment models, and healthcare reform. So that is where I would say that it has to be a multidisciplinary approach. There is no point in all of us sitting here listening to a big lecture and then winding up. So it is not going to take us anywhere. And I'll tell you my own experience in December. So I was at Harapnalli and my mother had a stroke in the morning. She had paralysis. And the first thing what is required at that point of time is they need a CT scan to see if there is a blood hemorrhage or there is an infarct. Because if it's hemorrhage, then it has to be opened and surgery has to be done. If it's an infarct, they have to give some antiplatelet drugs. By knowing only this much information, the patient's whole life can be saved if the scan is done at the right time. But where the hell the CT scan will come in Harapnalli? Because it's 1 crore. Definitely nobody will think about putting up a CT scan in a small town. So these are the challenges. That's where they say that healthcare reform and future payment models, research and innovation, yes, definitely it is required. But already the pure research is come to a very high level, wherein Indians and Indian institutes, it's very difficult to enter a pure research. We try to do something, it's already been done at a much faster level. And patient-centered radiology and information management. Supposing now there are some things, what is happening with computer-aided diagnosis, I'll come to that afterwards. So these are the things what they have thought. And then the future of radiology depends on research and on your support of it. That's what they say. And the private practice radiology communities, it relies on academic radiology departments. Like now I work at SS, so it's academic radiology department where a lot of things can be done. But when I work outside the medical institute, I am a private practitioner. So there, I may not be able to carry out the research activities. But there has to be mixture of both. Even the private practice part of it there has to be a component of research. And then we will have to train the new generation of radiologists. So even from the engineering perspective, training radiologists can happen remotely. Right now we are working on a concept called RadLearn, wherein if we can unify all the medical schools in our region, say about 5 medical schools. So if all their images can come to a common server, and whatever those interesting cases are there, not every patient will have those teaching material in it. Some of them, so there may be some complicated case which we want to discuss with our colleagues across our region. So the concept is like, if there can be a central server and all these medical institutions, say about 5 or 6 medical institutions, are able to push their interesting academic cases into this server, and all the students who are getting trained in these are able to log in to these forums, and they are able to go through all those cases. That means what? A person who is getting trained in Mumbai and a person who gets trained in Davangere, we can reduce the difference. So, but for all these we need a lot of technology, we need softwares, and these softwares and technology are already there. Why it is not happening with us? Because when I go to our management with this particular concept, they say, what is the cost? The cost is so much because the software company is not an Indian company. So if somebody can take up a lead step to do something indigenous, So that is what is going to connect all this. And what is the benefit of connecting all the medical institutions? So you have all these complicated radiology images which are getting interpreted at one level. So if all these complicated things need a second opinion, say you want to take an opinion from a doctor who is in Bangalore, so definitely on this forum you can take from Bangalore, or through the internet you can take an opinion from who is the best in that particular disease. That's what happened with Leander Paes, right? So he had neurocystic sarcosis. Why they were not able to diagnose? Why an Indian doctor was able to diagnose? Because Indian doctor had seen many of those things. Right? So population is our strength. Though it is a weakness in disguise, that is the strength in medical field. So we will have to utilize that. So definitely population will keep increasing. There will be no stop. Everybody is going to have 2 kids and it is going to be more only. It will never reduce. See, this is the real Indian situation. So we are talking about MRI and all these things. See, this is nothing. This is a photograph of villagers who are affected by fluorosis. And in Davangere, Chitradurga, Ballari, these are the beds for endemic fluorosis. The fluoride content in the water what we drink, that is so high that it is going to cause problem with the bones. In fact, my grandfather had fluorosis, and I think I would also have some amount of fluorosis changes in my bones because I drank water at Harpnelli for 15 years of my life, and now again I am drinking. So there is no way people have thought about these things. See, this is what happens. I think this photograph is from one of the Karnataka Andhra border region. So all the knee joints, everything is all curved. And these are the things which can be preventable. So if people take up these small problems which are around us and work on it, it will be very good. So I think most of this I have already spoken. It's a problem is cost, population, limited resource, lack of knowledge and lack of orientation of research and innovation. And we are paying high amount of our equipments which we can create with our own knowledge bank. So it's a necessity is mother of innovations. So ultimately we come down to if there can be low cost gadgets. See, ultrasound scanning machine, a typical machine will cost, a good machine from a good international vendor, MNCs, it will cost somewhere about 10 lakhs. But when I was at Coimbatore, there was a Mr. Ganesh who was an engineer from IIT Mumbai. So he had created his own ultrasound machine with the indigenous technology. A laptop works as a monitor as well as a keyboard for his ultrasound machine. He had created a thin panel and he had used whatever ultrasound will be generated, even if a highest end machine also, the basic principle physics is known to everyone. So basic physics principle, they can't patent it, right? So you take that and try to reduce the cost. So he had come up with a machine which costed only 2 lakhs. In fact, the Bihar state government had purchased a lot of his machines. But again, the problem is he will never get a support from a political people because they want the machine to be sold at 15 lakhs because they have put in money for their elections. So they have to get their 5 lakhs. So that is why it's a vicious cycle. It has to be a multidisciplinary approach. And Mr. Ganesh was very close connected with my boss in Coimbatore. And in fact, he couldn't go ahead with his next bigger, higher end ultrasound units. He was not able to do on the color Doppler, 3D, 4D because he was not getting that type of support for his product. Though his product was very good. In fact, it was very small, very compact. And now we are buying the same portable ultrasound machines from the bigger Philips G or whoever it is. We pay them about 10 lakhs and we buy from them. In fact, much better technologies people can develop here. And I think I told you the thing about radiography in all primary health centers. See, X-ray, I said the example of tuberculosis. It's such a rampant disease and tuberculosis is curable. A lot of national program is going on. But when you go back to a primary health center, there will be no X-ray there. And if the X-ray is there, the technician is not there. If X-ray technician is there, then the film will not be there. If the film is there, then the solution will not be there. So these kind of problems are there. And these all problems, we will never reach this quality healthcare. And why engineering is very important is it reduces cost for us. And in fact, believe me, you will make more money if you patent something directly in India rather than doing it in US. And issues is indigenous equipments can cost lower And manpower and technology, definitely teleradiology for reporting reduces manpower. See, this is what I told. If you have a team of medical colleges who are centrally connected with a server where all the images can come in, so any number of primary health centers would definitely push their images to that and get the expert opinion. So that's the advantage of the technology, that the doctor, even if he is not there, he is able to deliver an interpretation to a person who is getting. People have done it. Even Narayana have done it for a telemedicine venture. They have done for a ECGs. They have done, but it is not successful. It's not successfully running. If you go to a primary health center at grassroots, recently I visited a place called Nilgun. They have all those gadgets, but they are not able to do it. There is no manpower, and if manpower is there, then there is no power. Power is electricity is not there. And so what is the solution? So even if simple innovation like if a primary health center can run on an indigenously built solar for the medical equipments. Now my friend who is from a IIT and a radiologist, he is trying to run his diagnostic center on a solar power at Puttur. Puttur is a small town in Mangalore. He is my MBBS classmate. So he calculated, see, my electricity consumption is so much, definitely I'll have to bill the patient so much. So if I can reduce the electricity consumption of a diagnostic center, so that can reduce the cost to the patient. So he has worked on a solar panels which can give power to the X-ray machine and the ultrasound scan machine. Because these equipments will require power in different form. I don't know much physics about it. So they don't, they have all those high requirements, which the normal solar panels, they can only burn their lights and fans. But these things have to happen indigenous. Now today, even if you see solar energy, it's the American company which is launching so many solar products here. So why that should happen? That's all happening because somewhere at the bottom line, we are not able to put that hula in our students' brain to go and do this. And when it comes to ultrasound, we will have to be there, the doctor has to be there, he has to take the probe and he has to see. How many of you have got an ultrasound scan done? I think most of the women would have got it done during the pregnancy. So you see that a doctor is holding a probe and he puts it on the abdomen and the image comes on the console. So why there is a requirement of a doctor to sit and do it? So in fact it can be a technician, that's what they do in US. In US there is no radiologist who does ultrasound. It's a technician who does. And here what is happening here, we are all sitting and doing ultrasounds. In fact, those images, if they can be live streamed, see, live streaming can happen even on a YouTube, it can happen even on so many servers are there. If it can be live streamed to a central server, to a group of radiologists who are sitting at a headquarter. So all the 8 or 10 PHCs which are attached can have a ultrasound machine and a technician. So you have got people who have created low cost ultrasound. You have got people, there are so many people who are jobless. In fact, in the same city, there are people who have put an application to the district health officer saying, we are radiographers, we don't have jobs. Doctors are not appointing us. So there are so many people, in fact, who are trained. So these technologies can give jobs to people, but it can solve the problem. Why a pregnant lady has to travel 70 kilometers just to get an ultrasound scan done? When technology is there, we are not able to connect all these things together. So, in fact, I was reporting for Iran-Iraq, there was a conflict area. So, they have a hospital there called Ashraf. So, I used to do this 2 or 3 hours of live ultrasounds for them. So, they used to stream it, though it was not on a platform like a properly designed software. So, they had taken the help of some server where they used to stream their ultrasound images live. And there was a Google chat box which was parallelly, I was able to interact with them on a Google chat box, though I was not talking to them. So whatever they used to pull up their case for the week. So in a week, whatever they needed second opinion, so they used to show me those cases. So live. So if I ask them, can you just turn the probe little 90 degree and focus the gallbladder a little more and the kidney a little more. So they used to do that and I used to report that. So this was happening in 2011. But where are we? Have we progressed? No, we have not progressed. So there is a doctor who was doing this for a Iraq country, but why he is not doing it for our own Indian country? It's not possible. It's not happening because ultrasound machine here will cost. If you ask for a quotation, they will tell 12 lakhs. So there are machines which are 2 lakhs. There is a doctor who wants to do it, but there is no proper technology forum, or there are not much people who are supporting these things. And now come to the scenario 3, that's the CT scan and MRI scan. So already comprehensive teleradiology is existing. So in Bangalore we have a company called Teleradiology Solutions, which is headed by Dr. Arjun Kalandpur. He is a radiologist who was in US, and then he moved back to India. Now sitting at India, most of the time he is reporting for the American hospitals, because it pays more, right? So if you interpret one CT scan for an American hospital, you get the total CT scan charges of India actually. So the interpretation charge, if you take say about 15% of the cost, say sir has paid 10,000 for the MRI, so to the radiologist the interpretation charge may go for 1,000 rupees as his interpretation charge. But whereas if you report the same MRI for an American country, straight away you get about some 4,000 or 5,000. So when we have people, we have technology, only thing is this has to get unified. So when these things can happen is when all of us will work together. Supposing if there is a project where BIT, UBDT students and our JJMC students and students at SS and maybe some students from Basveshwara Medical College or SDM Dharwad, all of them, maybe the best of the students or something, can put together and then put their brains on it. I don't think anything is impossible. So that has to happen. So since it's a faculty development program, I'm little more stretching and going out of my topic, because this is what we should be looking at. Tomorrow if we want our healthcare cost to be less for us, when we grow old, we have to do this. Otherwise what will happen? Now it is 10,000, it will become 25,000 when we are retiring, and ours, whatever we get at the end of the retirement, now government say no pension. So some other scheme it will come out. Then it will become mess. See, this is where it has developed. See, ultrasound machines used to be so big. Now we have got these handheld devices. And this handheld device has come almost at 2007 or 8, it has come into the market already. So I am saying that don't try to innovate the same thing, because it's already there. Try and see how this can be utilized in Indian scenario. So can you make this device Wi-Fi, or can you put an internet into this device, and can you make this device send the images live stream to a server from where the radiologist can pick up. So then what happens? Somebody has met with an accident on a highway, even a paramedical staff, he could use this device to keep it on the liver. So if there is a pain there, so if the liver is damaged or he is bleeding from that, and then live stream, and the radiologist sees it and he says, so the accident has occurred between Harapnalli and Davangere if it has happened. At the moment this is seen, so they will say, okay, this particular case, it has to be dealt only at Davangere in a bigger hospital where many doctors are there, not at Harapnalli. So that reduces so much cost. Supposing the patient goes to Harapnalli government hospital, from there he gets referred to CG hospital, from there he gets referred to SS, and from there he goes to Bangalore. So there is a lot of wastage of time. Though we have technology, very soon all the environment will become Wi-Fi. Whether you like it or not, Wi-Fi environment is going to come up everywhere in next 5 or 10 years. So you walk around, so all those Wi-Fi will come. So we need to think in these new ways of utilizing whatever is already there. So we need to just think out of the box. Can there be a helmet CT scan? So the CT or MRI machines are so big, so can it reduce in the size? So if somebody wears a helmet, directly the image goes to the doctor's phone, and from there he reports it to the neurologist or a neurosurgeon directly. Straight away on the go, the patient knows whether he has to go to which particular doctor. So again, this can solar energy run our CT or MRI scanners, which can reduce running cost. And then coming to this data management, believe me, this data mining itself is a big thing in radiology. So nowadays we need a lot of data to do any kind of research. And since we have a lot of population and a lot of machines, we will be the ones who will be having maximum number of medical images or maximum number of images of diseases. If you put it, okay, we want to see the fingers of a 14-week fetus. So since Indians have a lot of population, a lot of people are pregnant at any point of time, definitely we can come up with that data. Okay, we want to see fingers of 14 weeks fetus in how many lakhs or how many crores. We can see so many because our birth rate is so high. But whereas what is happening? Some white-skinned person sitting at UK, he will be writing 14-week fetus, finger will look like this. How many fingers or how many hands of fetus he has seen? He would have seen about 10 or 11. That's all. So the data management is very, very crucial, and we are getting lost. In fact, this time's IJRI, which is our radiology journal, data mining itself is a full-length article somebody has written. So data mining has got a lot of scope in radiology circles. So supposing a whole data, radiology data of one person, right from the time when he gets scanned, when he is in his mother's womb, uterus, till his 60 years, everything is on one particular click. It's so good. Supposing when you go to your doctor, you only will forget when was the last time I met a doctor, when was a fracture I had, or when was a sugar detected. So do you know what was the date when you detected that you are a diabetic? Do you remember?
Around 10 years back.
No, date.
Date to exact date.
Yeah, see that has got a lot of bearing because exact date is something. So you may say 10 years. When you look back the date, today you go and try and see if you have maintained a 5, go and see. It will not be 10. Either it will be 9 or it will be 10 and a half. So it has got bearing because
Even the exact date I don't know. For some reasons I got tested for the sugar, then it was a positive.
No, but you need to know when was it then you are declared as a diabetic. Why is it essential? Because diabetes has got a natural course of history. See, at the end of 15 years or at the end of 20 years, there will be problems with eye. At the end of 25 years, there will be problem with kidney. At the end of 35 years, this is with uncontrolled diabetes. Uncontrolled, at this much time, you will get a heart attack. So if you know your timetable, I am sorry to say, you don't know your first date only. Right? So this is very crucial. So if there can be a data management software for every person in healthcare, it has got a lot of value. It has got a lot of value. Just if anybody takes up this whole project of having complete data of healthcare, it will be a lot of MB and lot of GB or lot of terabyte data for one particular person. Because one particular person will meet so many doctors, he will get transferred from one place to another, he will go to US, he will come back to Iraq and he will come back to India. So, but all the data has to be there at one click. So if you can come up with some company like that, that will be a great, even the US, they are working on these things, but they can't do these things because there are a lot of laws. They say that whatever images, what you have taken, whatever patient data is there, it has to be kept confidential. So if you have to keep it confidential, then you have to create some passwords. So, but if there are passwords, then there are hackers, right? So why do they hack? They want to know how many diabetics are there in India. So if I launch this particular chappals for diabetics, so how many are going to get sold? So for that data, people will sell their data. So they will say, see, I have exact data in Davangere city. There are 25,466 people with diabetes of more than 15 years. Oh, that means that many chappals only I should manufacture. And all those address you have. So you go and sell those chappals to them. Now because, see, you get a gangrene, you get your foot out of your body, right? So this is the beauty of having all the data. So data management itself is a very big thing for whole healthcare, and when it comes to radiology, you have taken a chest x-ray when you are joining a job. In a military persons or central government jobs, if you want to join a job, they do your health checkups. In private sector, usually they don't do because it's costly. So your chest x-ray as well as your ECG and your general health checkup at the starting of your career will be definitely done. But where is the data gone? So that time I think if it's a government job, they will check your sugar levels also. So did you ever try to keep it in your memory? In fact, my wife is a diabetic since last 5 months now. She got detected with diabetes. In fact, I also don't remember the date.
But from last 1 year, I am keeping the track of the.
No, that's very good, sir.
The level of the sugar.
So how are you keeping a track, sir?
I am writing it in a paper.
So
every time I am writing with the paper.
So if it is on an Android phone, on one application or on your email, which is dedicated only for your healthcare, I think that will be very wonderful, right? So you don't have headache of preserving that paper. So I am telling these type of innovations will not cost much. It doesn't require a big time laboratory. So it is all within us. So one of you can just think about diabetes and what can be done with data management. You will come out with all these things. Because I don't know whether everybody is computer science or biomedical engineering. I am telling a generic stuff. And now coming to playing with medical images. So these things I have told. Imagine if all the medical images acquired were to be permanently stored. What will be the storage capacity of servers? So typically one CT scan will cover, if it's a CT of chest or abdomen, it takes about 356 MB on a hard CD. So earlier we used to burn CD and give it to the patient. So if a busy center is doing say about 35 CT scans, so how many CDs you need? So you need 17 CD scans. 17 CDs you need. Of if it's a DVD, then maybe one DVD can host say about 10 to 12 scans. So it's very huge. So can there be a solution with regarding to the servers? Now cloud has come. Cloud computing is there. Cloud has come. But ultimately somebody somewhere is hosting the cloud, right? So can there be some sort of virtual cloud? So we need to think in those lines. Maybe I don't know what is the capacities and all this made up of. So if you can have still smaller, minute electronic devices which can store huge data. Say maybe about 10 terabyte can be stored in a chip which is much smaller than a nail. I think that is what is called.
Speeds are there.
I don't know about those things. They are already there. So, but then why are we not integrating? Thinking of integrating. So
That is superconducting device.
Superconducting. So maybe you can take up that project. So you know that small chip is there, whatever it is called, and think about developing a software which can put all the diabetics of Davangere into that and all the data on that. So definitely that will be a wonderful thing, because we all know things but we are failing to integrate. And then teleradiology I have already told, like I was telling like Medisoft ES cloud server, but ultimately cloud server is somebody is hosting a server somewhere in physical means. So this is what typically happens with this is a modality and this is a source fax. From here the images get pushed to the cloud. From cloud it can go to the remote reporting, it can go to the referring doctor, it can go for a second opinion, it can go to a destination fax, it can go for reporting at source. So all these things are already happening. So we have to think little beyond this. And this was one of the project which we did with the engineering student, remote access of radiological images using Android. And I think the lead student Vinay who was there, I think he's gone to Germany for one more project. So these are some things like from the Android phones you could access the server and the images will come on that. See again one more thing is mobility in healthcare and imaging. See that's what, with 5.3 billion mobile subscribers, mobility in healthcare has taken off and is having an increasingly profound effect on practice of radiology and medicine. As an entire new generation of radiologists with an innate level of comfort with these mobile devices emerges, highlights several opportunities for radiology imaging as a goal to leverage mobile technology for improved patient care. So though it is all, it's little bit which is out of the way, I would tell it simple. I am sitting here, standing in front of you. So there is some particular scan which happens at the college. So I want to see it on my Android phone. So if I am able to see it, so that is changing the way how we are looking at it. So earlier days, illa wait ಮಾಡಿ doctor ಬರ್ತಾರೆ ಊಟಕ್ಕೆ ಹೋಗಿದ್ದಾರೆ. So now that particular waiting point is not there due to the mobile technology. And now coming to the voice recognition. So voice recognition is been already being used since last, I think when I was in +2 also already I had my chartered accountant uncle who used to visit UK. So they were already using voice recognition for their accounts. So they used to have this voice recognition software which used to speech to text conversion was already happening. So now we need those devices at a lower cost for our usage, for our accent. So that is where we are lacking. So if I buy, it doesn't take anything. I'll just log into some international website, order for a Dragon. So Dragon is a company which manufactures these speech to text converter devices and software. So, but the problem is they don't have Indian accent. So either I have to learn European or a British or a American or a Australian accent and then report my Indian report in an American accent to get it typed. So why are we not working on those things? And Dragon has come up with the Indian version, but it's very expensive. It costs about, say, about 80 or 90,000 rupees to buy one Dragon for Indian accent. But it's not original Indian accent. It's developed by some people who are there. But if you will have to match with so many radiologists of India who speak things differently. A Tamil radiologist will tell it in different way. Karnataka radiologist will tell it in different way. A UK returned Indian radiologist with a Tamilian will tell it in different way. And that's all. Voice recognition is here. It's like a phrase actually, comma, like it or not, period. So there are a lot of things which comes up with voice recognition also. And there will be voice recognition errors are also there. So if these are the errors, and this is the area for research actually. So these are the problems what are there with the voice recognition presently with regarding to radiology reporting. So people can pick up these things and try and do with the voice recognition. And there are a lot of things, pros and cons for using voice recognition. If I say hypodense, it may type it as hyperdense. And if I say bleed, it may write it as something else. So there is always plus or minus, but definitely it will reduce the time. And now new things is we have computer aided diagnostics, where in the computer, whatever, if an X-ray is given to me, I see it. So what is the process, what goes behind telling a report? The X-ray image goes to my retina. From my retina, it goes to the occipital cortex. Occipital cortex is a center for vision. And from there, it goes to the frontal cortex and temporal cortex. Temporal cortex of the brain has got memory, and frontal cortex has got speech or words. So the moment somebody gives me an X-ray, my eyes has to transmit that particular image to my occipital cortex. Occipital cortex will register the image and send it to the temporal cortex. Temporal cortex will match this X-ray image with all the prior X-ray images what my brain has learned. Plus it will use the knowledge of the frontal cortex, and then it says, yes, this matches with the normal. Then frontal cortex tells my mouth to spell normal chest X-ray. So this whole process takes hardly, not even fraction of a second. So if you show me an X-ray, it takes so fast. So can we devise these type of computers who can artificially read and interpret these things? This is already happening. People are able to come up with softwares which can put a circles over the doubtful area on mammograms. Chest X-rays they have done, and even on the CT scans they are able to come up with and say that, okay, this is blood. Just like how earlier days, if you have taken ECG, one long strip will come. Now if you take a ECG, it has got a interpretation by the computer. So same way radiology also can happen. There can be interpretation by artificial intelligence. So once the artificial intelligence develops to that extent, then whatever you have got lack of number of doctors and radiologists, it will match. In fact, doctors can do much better work. Supposing in UK they say after reading 10 CT scans the doctor is tired, he is not supposed to interpret any more images because he will commit mistake. So by law he cannot do more work, and that is the reason why they are able to deliver the quality healthcare. So we are not able to deliver the quality healthcare because at 2 o'clock I still have about 5-6 patients more to be seen, and the numbers what I would have seen is I would have already done about say 15 or 20. So we work more. So then what happens? Our quality reduces. So if you have got the voice recognition software, so in a busy radiology center you ask, scan aito, reporting muntas kairo. Where is the flaw? Flaw is at the level of typist. Because typist has gone through some schooling and she has become a typist because she is not able to enter some professional course. At the end of it, she is not well trained also. But if we have all these things, if the typist is still there, I am not saying remove the human component. There is a voice to text conversion, she will have to only correct the errors what the machine has done. Same way thing can happen for radiology interpretation also. Because one CT scan images, one set of thorax will have about 700-800 images. So would you like your radiologist to just quickly scroll through in 5 seconds and say normal, or would you want your radiologist to spend enough time on your scan? So if your radiologist has to spend enough time on your scan, you need all these new things which will come into practice. Only then quality can come up in healthcare. See, I have told you this process. How does this two things This is a normal and this is abnormal. It matches and it takes. I have told you all these things. Yeah, can computers replace radiologist skills? It's absolutely no. Whatever ECG interpretation machines have come up, so they say, some of the ECG interpretation machine, they say that the patient is dead. The patient will get the same ECG to the doctor. Sorry, they the report noted. So machines can't be foolproof. They can only be trained to help us do things in a much better way. See, already these computer-aided devices, right? They are doing identification of prompt colonic polyps, and I think this is a little bit pure radiology. Let's skip these things. See, all put together, we have large population, large database of images, and central server for storage of all images. So, supposing I told you a scenario, all the medical colleges are putting all their images in a server, and if you have that full database from all over pan-India, definitely any computer can be trained to match that particular thing with the existing database. And then softwares, apps and websites, this I already told. And now, just yesterday I was just seeing an email from one of my colleague in G. He keeps sending me updates what's happening latest. So there is something called as micro bubbles. So ultrasound depends on the image, ultrasound passes through the body, and there is a reflection and there is a rarefaction. Whatever is reflected, again the sound energy is taken and image is created. So they are creating these micro bubbles which contains a lot of air. So they will be reflectors. So if you can inject these micro bubbles and keep your probe on a heart, what they have done. So you can see these bubbles coming into the heart and going out of the heart. So that means this is much better than the conventionally what we have called as color Doppler. This is little more advanced than that. And with these microbubble technology they are working on. So if you can trace these microbubbles where they are going from your ultrasound machine, so then if you have a cancer which is sitting in liver, so you want the drug directly to go to only that particular area. So you can tag these microbubbles with the drug and send it. So, and why will it go only in liver? There are particulates which will be metabolized only by liver. So you tag those particles also. Then wherever you inject, it goes only to liver. So the drug gets delivered only to the liver. So what is the benefit? The anti-cancer drug will not make you lose your hairs, will not suppress your bone marrow, you will not become weak. So these are the levels of research what people sitting on the other side of the world, they are doing it. Problem with them is they don't have a population to test all this. So recently I got one more American radiologist, Indian radiologist in America. He said, I got a whole project of a PET CT scan. Can you suggest where I can put it? I asked, why do you have to put it? No, yaar, हमने जितना भी किया है, whatever we have done, it's done on very limited numbers. Now we want to test it on many huge numbers. And India is the best country to get huge number of cancers. Because population is more, we have a lot of cancers. Their population is less, they have less cancer. So when they have to validate the research, they need numbers. So let us not become guinea pigs for their research. Let us do things on our own. I think that is what should drive all of us to put that particular pula in our students' brain. See, you have got to do this. And I think with this I will be ending my talk. It's multidisciplinary approach. In fact, it has to be radiologists, physicists, physicians, biomedical engineers, social organizations, politicians, and it has to be borderless alliances across the geographies. And it has to be target oriented. It has to be low cost equipment, and ultimate goal should be Sarve Jano Sukhino Bhavantu. It's not that it's the Japanese or Chinese who are manufacturing the MRI scan at 1.5 crores instead of the US manufacturing at 3 crores. So ultimately it's people who have to get benefited. At the end of the day, it's a human life. What is more important rather than whether it is Japanese or Americans or who has done it. So what I am saying is, we are little behind, but we can go ahead of them because we have population. So if they have to do any research here, they have to come all the way from there to here. In fact, the Japanese company, teleradiology company, they were surprised to see the amount of places which do not have CT scans here. Because they are the leading teleradiology company. So they have their own technology wherein they have mini servers. Mini servers will be kept at individual radiologist's house as well as the hospitals. The moment the images are coming into their mini servers, simultaneously it goes to the radiologist's house also. And if the radiologist, now they are working on the Wi-Fi stuff. So if the mini server has to be connected to a desktop and they can report. So now after they came here and when we gave them an input, see, if I am sitting in a garden with my family, still I should be able to see the images on my iPad. So can you do this technology for Wi-Fi? They said, yes sir, we are working on this. So they are able to work all on this, but ultimately when they have to utilize it, they will have to come to a country like this. So we need to have borderless alliances. We need to partner with foreign universities, we need to partner with them. So only then things will look like. I think most of you who are sitting here will have at least one close friend who is sitting at US. Try and get connected with them. Try and see if you can get some sort of a research project collaboration with them. Try and do that. Though out of 1,000 things, if out of all, maybe about 40 people may be here, if 10 of you have connects, 10 people respond positively. Even if one becomes little successful, it's a great leap. So try and connect with people across the globe to train your students also. So these are my some of references. With this I end my lecture. Hope I have not bored any of you. So if there are any inputs from anyone